welcome everybody. I welcome you again to another session of Pulmonology Read Aloud. My name is Dr. Anshamani Arora. I'm a practicing pulmonologist in Gurgaon, India, and I am presenting the Read Aloud for GINA Guidelines 2022 today. So, the Global Initiative for Asthma Committee reviews its guidelines twice every year and presents an updated report on managing asthma. And we'll be discussing about the recent 2022 guideline change. This is an easy to download article, easy to download PPT, which is available on the GINA guideline website. You can go and download the full GINA report, the changes, and even a PDF of changes line by line, page to page in an exhaustive manner. But today my job is to read quickly the current guideline changes so that you and I are aware of how to incorporate it in our practice. So let's get started. So the GINA guidelines has given a lot of emphasis on the correct diagnosis of asthma. It's important to recognize that whenever we are diagnosing anybody with asthma, we must have a demonstrable variability in the respiratory symptoms, whether this is seasonal, whether it is diurnal, or whether it is pre and post bronchodilatory medication. And it is important to demonstrate this variability in expiratory flow limitation by testing. GINA guidelines take this factor into account that spirometry pre and post bronchodilator is one of the most accessible and useful tests for testing variability in airflow and should be available universally. They also lay emphasis that you must try to first diagnose the patient and test him before treating whenever possible. However, if a patient lands up in an exacerbation or an acute condition, we may delay this, but whenever possible, please try to test and prove the diagnosis. This is the flow chart which gives us a detailed view of how to diagnose any patient suspected of asthma. So, let me summarize this quickly. So, if a patient with respiratory symptoms like cough, breathlessness, chest tightness, and wheezing comes to you and you feel that the symptoms are suspected for asthma, you take a detailed history and see if it supports asthma. If it does, if your patient is already taking some controller treatment from outside, if he is already on a combination inhaler, then in that case, you will have to change your approach to diagnosing him. You will have to still perform the diagnostic testing after stopping the inhalers for the particular time, which we'll discuss later. But if he is a treatment naive patient, you should try to perform spirometry. If that is not available and it's a limited resource setting, at least do a peak flow reading and check for reversibility. Now, if your spirometry or PF reading supports asthma diagnosis, you treat him. If you are not seeing a patient who is a new patient and this patient has come to you with an exacerbation but he's already on certain medication, you treat the clinical urgency with empiric treatment for asthma, and then you have to review his response. Once he's better, you have to do diagnostic testing, but preferably do this test within 1 to 3 months of first presentation to you. Now, if this patient did a spirometry but the results do not show a variability or an improvement in bronchodilator response, you have to suspect other diagnosis, do other testing, and if the diagnosis is still not confirmed based on our two most important factors of variability in history and variability in airflow on demonstration and testing, you must consider alternative diagnosis treatment. If your patient does not have a typical history of asthma, right away go for other causes of breathlessness and try to treat them. So this is how in a nutshell you would treat a patient who has come to you for the first time with respiratory symptoms suspected for asthma. Now, what if this patient is already on some form of treatment? He has been prescribed inhalers but comes to you, and you as a specialist want to confirm and prove that his diagnosis is correct. So, if this patient does give a variable airflow limitation, testing history, and his symptoms keep changing throughout the year, then the diagnosis should be confirmed, and then you can assess what is his level of control and see whether his controller treatment is in the right direction. Now, this patient does have a history such as suspected, but there is no airflow limitation which is variable on PFT. What would you do? So, if the PFT does not support your diagnosis, you consider repeating the spirometry. And how will we repeat the spirometry? We have to withhold our bronchodilators, and this is a very important takeaway point here. You have to withhold the bronchodilators. So remember that this has to be done for 4 hours for a short-acting beta agonist. So he's on Asthalin, he's on salbutamol, he's on ipratropium. Stop it for 4 hours. If he's taking twice daily ICS LABA combination, stop it for 24 hours before coming to you if it's twice daily. And if he's taking the longer acting, ultra long acting ICS LABA combinations, stop it for 36 hours. Or when the patient has come to us for during symptoms, then again you may prefer to test him later. Between visits, we have to check whether the patient is having a good variability in FEV1 and there is a responsiveness to bronchodilator. Now we've done all of it, yet his PFT comes normal. Then we're probably not dealing with asthma. Let's go to other diagnosis. Now, if this patient undergoes PFT and we find that he has a very good FEV1, so it is more than 70% predicted, it is not low, what shall we do? We should step down his controller to avoid giving him over medication because his FEV1 is good, and then we must reassess him within a month and see whether this stepping down is causing any harm or the patient is still stable. They also mention considering a bronchial provocation test or repeating bronchodilator responsiveness to confirm your diagnosis in these patients. If, however, the patient has a reduced FEV1 on your testing, then step up his controllers. And how long? Another very important point, for 3 months. Give him a better dose of a controller for 3 months, and then only you shall step down it later, right? And reassess his symptoms. If there is no response, resume the previous treatment. So this is a very, very important slide to understand how to manage our patients. Now, if this patient came to us with fewer respiratory symptoms and his lung function was also normal and the PFT did not demonstrate any variability in airflow, what do we do? Now again, you still are suspecting asthma. Please repeat the bronchodilator responsiveness test again, but withhold the bronchodilators as noted earlier and then only repeat the PFT. If this patient still has a normal report, please step down the controller. Do not give him excess steroids. And now if his symptoms re-emerge and we see that in next visit his lung functions are failing, then even if this patient had a normal initial report, his asthma is confirmed, go back to the previous effective dose of controller, the least effective dose of controller. Now if you step down this patient on controllers and the patient was all right and he did not have any increased symptoms, then cease the controller because your PFT is normal, there is not much evidence of variable symptoms, patient did not deteriorate on reducing the controller, so stop it and monitor him closely. For how long? For at least 1 year, so that you take into account all seasonal variations. However, the fourth group of patient may be a patient who is coming with persistent breathlessness, persistent airflow limitation despite treatment. Then step up the controller. How long? Again 3 months. Reassess, 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 and recheck the lung function. Now you have stepped up, he's not responding anymore. Then probably you should give him the same treatment dose that he was earlier receiving before stepping up, because the step up did not help him. And now you diagnose and investigate him for other possibilities, including an overlap with COPD, including assessment for severe asthma. So this is one take-home slide which we have to remember. Remember the 4-hour SABA, the 24-hour for ICS LABA, and the 36-hour withhold for ultra LABA and ICS. Coming to peak flowmetry. So in a resource limited environment, GINA acknowledges that all countries may not have accessibility to spirometry everywhere. Expiratory flow readings can be taken into account. And here, when you are looking for response, then a more than 20% increase in the PEF 15 minutes after 2 puffs of salbutamol. So it's like a post bronchodilatory test. We are looking for more than 20% PEF improvement as compared to 12% or 200 ml in a pulmonary function test in the spirometry. Then asthma is likely. And once you send this patient home, he comes back to you, he should have a better improvement in symptoms and PEF after 4 weeks of treatment. So this is also one way in which we can establish and confirm a diagnosis and manage our patients. Let's come to the treatment algorithm. This beautiful algorithm has been there with GINA. We've always had it in every change, every update, and this year as well, this algorithm has been presented to us with a few additions. So let's look at it in a glimpse, and then let's divide it and see what it says. So when we are treating patients who are adults and adolescents above 12 years, there are 2 tracks which have been recommended, which were there also in the previous statement, track 1 and track 2. So if I go back to this slide, then you will see that there are 2 tracks that we can really look at. Now, the track 1 is the preferred track, and this track says that even mild asthmatics have to be started on low dose ICS formoterol. So ICS LABA low dose as reliever. That is the preferred strategy. So a lot of emphasis and a lot of importance is being laid on the point that short acting broncho beta agonists are not your preferred reliever anymore. Do not tell your patient to use a SABA SOS. Do not tell him that he must take this SABA every time he feels an increase in symptoms. That is no longer the right approach. And point and again, the guidelines emphasize that the preferred strategy for reliever will be a low dose ICS and formoterol, rather MART therapy, single inhaler for maintenance and relief therapy. Why? Because that reduces the risk of exacerbations, that reduces the risk of progression of the exacerbation, and patient has a similar symptom control even immediately, and he has a good lung function improvement, and there's enough evidence to support that SABA SOS is not to be used for managing exacerbations even in so-called mild asthmatics. The track 2 is the other track, which is the optional track, but a lot of importance is attached to the point that this alternative track is a non-preferred strategy. We do not want to use SABA as the reliever in our patients, but this option of a track 2 has been given where SABA can be used but is not preferred. And why? Because it is less effective. 2, we would not want to risk further progression of exacerbations and therefore mortalities in asthma. So use track 2 only if track 1 is not possible, and also consider track 2 only if patient is otherwise well acquainted with his controller, he knows how to use it, and he's very stable. He would rather not even require it. You're just mentioning it because you want to tell him about a reliever. And before we consider this regimen with a SABA reliever, please consider whether this patient will be adherent with the controller. He should not become over dependent on the SABA is the point to drive home. And if they are still using the SABA too much for relief and avoiding controller, they are at risk of SABA only treatments. And what about the other medications, the other controllers? They have limited indications, lesser efficacy. So track 1 and track 2 still remain our primary treatment, track 1 majorly. The newer change that has been added this year in this flowchart is also of step 5. In step 5, a newer class of biologic therapy has been added, and which the step 5 already had the provision of adding a LAMA, which we have seen. We have also seen a role of triple therapy in asthma in step 5, and this was already there. But the newer therapy that has been added in biologics is anti-TSLP. Anti-TSLP is anti-thymic stromal lymphopoietin. So thymic stromal lymphopoietin is a cytokine basically, and this mediates the signaling for inflammation. And if we are able to stop this, the release of cytokines and the Th2 inflammation in asthma, by blocking this, then we may achieve a better cure. And that's how anti-TSLP tezepelumab has been added in step 5, still not available in India. Anti-IL-4 dupilumab has also been added. We already were having anti-IgE omalizumab and anti-IL-5 benralizumab options previously. So add on the LAMA, assess the phenotype, consider a high-dose maintenance ICS formoterol, and this new biologic may also be considered in step 5 in future. Now let's talk about personalized asthma management. Let's break down the flowchart that was given into individual components. Remember, for all your patients, assess the patient, adjust the dose every time you assess, and review the response. So confirm the diagnosis, very important. Control the symptoms, risk factors, comorbidities. Adjust the dose, treat the risk factors, give other strategies. Make sure you're adjusting up and down between the tracks or between the doses, and keep reviewing the patients for side effects, exacerbations, and symptoms. In adults and adolescents, preferred track, controller, preferred reliever will be ICS formoterol. Step 1, step 2, no more SABA, only as needed low dose ICS formoterol as controller and reliever. Step 3, low dose maintenance instead of as needed, maintenance ICS formoterol. Step 4, medium dose maintenance ICS formoterol, and step 5 as we discussed. In the alternative strategy, track 2, before considering, make sure he still takes his daily controller. Here, step 1, take ICS whenever you are taking SABA. So if you're using SABA SOS, please do not forget to take your controller. For reliever, then you can add as needed SABA. Remember, this is not preferred strategy. Step 2, low dose maintenance ICS. Step 3, low dose maintenance ICS with LABA. Step 4, medium to high dose maintenance ICS and LABA. And step 5 is the same. Now, other controller options, do not depend on them. Another thing to drive home, do not depend on additional options like LTRAs, add-on LTRAs, add-on slits only for management. So low dose ICS, whenever SABA is taken, to be given. Daily LTRA is additional option, less efficacious, and addition of sublingual immunotherapy for house dust mite is also an additional controller. Here we go to medium dose ICS, or we add LAMA in the next step, or LTRA, or house dust mite sublingual immunotherapy, or we switch to a higher dose of ICS. And in step 5, they mentioned addition of azithromycin in adults, or addition of regular LTRA, leukotriene receptor antagonist like montelukast, and as a last resort, adding low dose oral corticosteroids, but this is not the preferred strategy. Why should we not treat with SABA alone? The guideline mentions time and again that this fundamental change, which was brought about in 2019, continues to hold true with newer meta-analysis coming. Regular use of SABA, even for up to 2 weeks, will cause increased airway hyperresponsiveness, reduction in the effect of the bronchodilators, increase in allergic response and eosinophils. So do not use SABA too much. It will cause more exacerbation, poorer control of asthma, and more mortality. The evidence comes primarily from SIGMA trials, Sigma 1 and Sigma 2 trials, where the rate of severe exacerbation was more in patients who were taking as needed SABA, in this case terbutaline, compared to as needed budesonide and formoterol. And the newer evidence on as needed ICS formoterol also comes from Bateman study 2021 and the Beasley group of 2019, where they have mentioned that if a patient is taking as needed budesonide and formoterol, then the number of exacerbations annually will be lesser as compared to the patient who's not doing so. And we can see it in both the groups. So a lower risk of exacerbations compared to daily ICS plus as needed SABA. What are the changes newer in the recommendations? The recommendations mention that LAMA should not be used as asthma monotherapy. And when you add LAMA to ICS LABA, you should acknowledge the fact that LAMA is not going to increase the lung function too much. LAMA is not going to improve the benefit of symptom too much, so do not give it only for symptomatic relief. It will cause a modest reduction in exacerbations, but make sure they are on the right dose of ICS LABA before you add your LAMA. And recently, all chromone PMDIs have been discontinued in asthma management. This is a separate entity within the 2022 guidelines, which is the GINA guide for difficult to treat and severe asthma. It's beyond the purview of today's talk, and maybe I can make another video and read aloud on this. Please let me know in the comment section if you would like to have this video. Let's come to changes in treatment in 6 to 11 years old. This is a glimpse of how it looks like. Let's dissect it and see it individually. Major changes are that when you're treating patients 6 years and above, then controllers have very limited indications and will not be preferred. And in the 6 to 11 year age group, again in step 5, there is an approval for dupilumab anti-IL-4 for children with severe eosinophilic Th2 asthma who are not on oral steroids. And please consider oral corticosteroids as maintenance for children only as a last resort when everything fails. Coming to the individual parts of the flowchart, again like adults, assess, adjust and review the child at each visit. The step 1 involves preferred strategy, low dose ICS whenever your SABA is being taken. And other controller option would include daily low dose ICS. But these patients can use as needed short-acting beta agonist or as needed ICS formoterol reliever in MART therapy if they are already in step 3 and 4. So again, in children like adults, you can still use the ICS formoterol if they are already in step 3-4. You can use SABA SOS if they are in the lower steps, And the preferred will be, whenever you're giving SABA, give a low dose ICS. Step 2, daily the child should be taking a low dose inhaled corticosteroid. This is not with LABA, it's just inhaled corticosteroid. Daily the child should be taking a low dose inhaled corticosteroid. This is not with LABA, it's just inhaled corticosteroid. And other controllers have limited role like leukotriene receptor antagonists or low dose ICS plus SABA. Step 3, preferred will be that this patient should now be on low dose ICS with LABA or a medium dose of ICS or a very low dose ICS formoterol maintenance MART therapy, right? And step 4, you increase the dose to a medium dose of ICS LABA or a low dose of maintenance and reliever. And step 5, children should be assessed for phenotype. A higher dose of ICS LABA can be given, and 2 therapies are recommended now for children in biologics: anti-IgE omalizumab and anti-IL-4 dupilumab. But again, they are to be added as a last resort once we have made sure that all the steps have been taken care of. What about VZ preschool children who are less than 5? We see a lot of them even as adult pulmonologists. Remember that if these patients do not have interval symptoms and they just come to you with a VZ episode for an opinion, you can give intermittent short courses of inhaled corticosteroids along with the SABA, but only give intermittent short ICS if you know that this will be used appropriately. We do not want the child to be on a long-lasting inhaled corticosteroid in such an age, and oral bronchodilatory therapy, oral salbutamol therapy is not recommended. For 5 years and below, this is how the flowchart looks like. Much similar, but you can consider intermittent short courses just when he has a VZ viral illness or a VARLI as it is called, and we step up with a daily low dose ICS or a double low dose ICS, and in step 4 we continue the controller. And in these patients the dose has to be really taken into consideration, and they've also given in which children you can consider these steps. So how to divide them into steps. Amongst the definitions, a very clear demarcation has been made of severe asthma and difficult to treat asthma. Difficult to treat asthma is the one where you're not able to treat because of other factors like adherence, the technique of inhaler, the comorbidities. But severe asthma is the umbrella where the disease is remaining uncontrolled despite your optimized treatment, and we are giving a high dose of ICS LABA so that it doesn't become uncontrolled. And a lot of emphasis has been given on mild asthma definition, and for mild asthma, it is the asthma which is well controlled on a low dose ICS or as needed ICS formoterol. But patients and clinicians should not assume that mild asthma means no risk and no controller. Mild asthma means it is well controlled. So do not be over dependent on SABAs, because up to 30% asthma deaths can occur in patients who have infrequent symptoms, and rather the GINA guidelines say that the term mild asthma may be avoided because it gives a false impression of a milder disease. Other important points are that a written asthma action plan should be given, so a customized asthma action plan, not just verbally telling the patient. In an acute setting, though salbutamol is usually used for immediate nebulization, formoterol has a similar efficacy. It can be used in emergency department, and budesonide formoterol combination can have as good efficacy and safety as a SABA. And air filters or purifiers can be recommended to asthmatic patients, but there's still no evidence of a consistent benefit on asthma outcomes. And another point made mention is that e-cigarettes will have increased respiratory symptoms and asthma exacerbation. Then, just like the severe asthma, there is another guidance given on COVID-19 and asthma, which can be again downloaded easily. The main points are that patients with asthma are not at an increased risk of COVID-19. They are not at an increased risk of death if they are well controlled. So they must be encouraged to use good asthma management. Note has been made about nebulizers to be avoided in general care settings for patients with asthma because of risk of aerosol dissemination. And rather, it's been noted that there have been decreased asthma exacerbations somehow worldwide during the pandemic, and this could be because the patients have been more indoors. So this is all from me today. We have read aloud the changes in the guidelines, the main points of the guidelines. Do download the guideline, read the report. It is a very good article, and keep reading. Thank you for your patient listening.